Hello, everyone. This is Prateek Sharma from Kansas City, and it's my pleasure and honor to participate in this wonderful international conference. My task is to talk about surveillance in patients with Barrett's esophagus, but what I thought would also spend a couple of minutes on screening for Barrett's esophagus before getting into surveillance. Screening is important because that's how you diagnose a patient with Barrett's esophagus. And only after you've made a correct diagnosis on screening, you then enroll the patient in surveillance protocols, which we will be discussing later. So it's important to know the prevalence of Barrett's esophagus, which patients should you consider doing an endoscopy, and then making an appropriate diagnosis of Barrett's esophagus. So these are all very critical questions. So let's start off with what's the prevalence. This is a recent publication looking at the global prevalence of Barrett's esophagus. This included 80 studies in the general population and 23 studies with only GERD. And you can see that there is a nice east and west divide. And the population prevalence of Barrett's esophagus is significantly higher in the west as compared to the east. So 1% of the general population or 0.5% in the east as compared to 2%. And in the GERD population, it's about 5% in the east as compared to 10% in the west. So depending on where you're practicing, you may be seeing this difference as well. What are some risk factors that you should be considering? Reflux symptoms, smoking, central obesity, a family history, and age, either 50 or 60 years or older, are those that you should consider screening or doing an upper endoscopy. Finally, making a diagnosis of Barrett's esophagus can sometimes be tricky. So make sure that the patient does have Barrett's esophagus. And this is what it would look like, is you recognize the gastroesophageal junction, measure the circumferential extent of Barrett's esophagus, and then the maximal extent of Barrett's esophagus. How would it look like on endoscopy? Here's a patient. You can see there's no circumferential extent. This patient has a C0 M2 Barrett's esophagus. So what does this look like endoscopically? You can see there is no circumferential Barrett's esophagus. This patient has a C0 M2 Barrett's esophagus. On the other hand, look at this patient. This appears to be a mildly irregular Z-line. There is really no endoscopic evidence of Barrett's esophagus, not even at the X. So try not to take biopsies from that area and don't call this as Barrett's esophagus. So now at least we have diagnosis of Barrett's esophagus and screening out of the way. Let's look at surveillance programs and how you can enhance the diagnosis of neoplasia and cancer in your patient population. Some key steps. Have you inspected the segment carefully? Are you taking adequate biopsies? Are your surveillance intervals appropriate? So these are very important to improve your protocol of surveying patients with Barrett's esophagus. So let's look at the first couple of those pearls. It's important to recognize that a lot of cancers in patients with Barrett's esophagus get missed. This is a meta-analysis of several published studies in which these investigators from the Mayo Clinic wanted to answer the question that out of all Barrett's cancers, how many were detected within the first year of the initial diagnosis of Barrett's esophagus? So today, you don't have cancer, but you have Barrett's, and then within 1 year, you have cancer. It's probably that these cancers were missed, okay? So that's what they wanted to determine. What they found was that of all these cancers, 20 to 25% of these cancers were detected within the first year of the index endoscopy. Now, how can that happen? This is one good example. You can see in this patient who was referred to us with low-grade dysplasia. As we are coming back slowly with the endoscope, there is an early adenocarcinoma at the 12 o'clock position in this patient right there. There was no mention of adenocarcinoma on this patient's endoscopy. Look how clean the esophagus is and what a careful withdrawal that is being done in this patient. So the next concept to remember is the Barrett's inspection time. The Barrett's inspection time is the amount of time you take spending in the distal esophagus, washing, cleaning, and examining the mucosa. In this study, what was shown that if you had a very short inspection time, about a minute or so, you had a very low detection rate of high-grade and cancer. As your inspection time increased to 4, 5, 6 minutes, you were able to diagnose more patients with high-grade dysplasia and adenocarcinoma. So another pearl for you to remember in your practice on how to improve surveillance protocols. You can use NBI, BLI in your practice. Here's an example, magnification, virtual chromoendoscopy, and you can start looking at these very subtle patterns and classifications using the Blink classification with BLI or the Bing classification with NBI shows a very high negative predictive value looking at these. So you can use this in your practice to improve your surveillance protocols. Next is, what should these surveillance intervals be? Well, it's based on the grade of dysplasia. This is the medical position statement from several GI societies, and they say that surveillance should be done. And if there is no dysplasia, every 3 to 5 years, and I'll end up my talk with a more recent paper in JAMA that we had talking about this specifically, but remember, this is what you should be doing. Do we actually do this in clinical practice? And the answer is probably not. This is a meta-analysis of 14,000 patients with Barrett's and close to 5,000 endoscopists. And if you look at adherence to the surveillance interval, only 50%. If you look at adherence to the Seattle protocol, again, only 50%. So what it means that only half of us as endoscopists are actually following surveillance protocols in patients with Barrett's esophagus. So what can you do about it? Well, training is important. And this is a study I'll share with you, and there are several studies on this. These group of investigators from the UK looked at two groups of endoscopists, Group A and Group B. Group A were trained endoscopists in Barrett's. They were told about the Prague classification, the Seattle protocol, lesion detection, something that all of you listening to this today have already undergone. And Group B are general endoscopists without any specific training. You can see from this study that Group A endoscopists were more likely to follow the Prague criteria and the Seattle protocol as compared to Group B endoscopists. But more importantly, the dysplasia detection was significantly higher in Group A or the trained endoscopists. So all of us should try to be in Group A rather than in Group B so that we can improve outcomes of our patients with Barrett's esophagus in our patient population. What's next for improving surveillance in the future? One, I think, is personalized medicine, so you can apply certain rules to your patient. And of course, you cannot talk about endoscopy without referring to artificial intelligence, which again will be playing a major role in the future for surveillance protocols in our patients with Barrett's esophagus. So let's talk about personalized medicine. What are the factors associated with surveillance progression? This is a study which looked at 20 studies 75,000 patients. And what they determined is that age, gender, being a man, smoking, length of Barrett's esophagus, and baseline presence of low-grade dysplasia were all risk factors associated with progression. PPIs and statins were shown to be protective in this meta-analysis. So how can you put this in practice? This is where the next study comes into place, which was published in Gastroenterology a few years ago. They looked at close to 3,000 patients with Barrett's with 6 years of follow-up, and they developed a model. And in this model, they gave points to each one of these risk factors that we talked about: males, cigarette smoking, length, and presence of low-grade dysplasia. When the patient had points between 0 to 16, they had an extremely low risk of progression. Points between 17 to 24, intermediate risk. And if the patient had 25 or more points, extremely high risk of progression. So this is personalized medicine at the best. You apply this to your patient population, and then you can decide what to do with that individual patient based on surveillance. Perhaps you want to bring them more frequently for surveillance if they're in the high risk category or intermediate category. Low risk category, maybe you can even extend it beyond 5 years. So this is something which will be applied in the near future. The second thing, of course, is AI helping us in our surveillance protocols. This is looking at virtual chromoendoscopy, and this is the bounding box which appears. And of course, it tells you also the percentage of probability that there is cancer or neoplasia within this area. So you can see that in the future, this will help us. Where to take biopsies, what to resect, and so both for surveillance and treatment. That's one way of looking at it. The next is looking at this by using a heat map technique. And this allows us to look at this area, and at the bottom you see the blue bar, which tells you the probability. So here's an area, flat area, nothing appears abnormal on high definition white light endoscopy, and you get the heat map signature, which shows no cancer, and the predicted probability of cancer is 0%. On the other hand, look at this area. You're coming to this area, you see a Paris 2A plus 2C lesion here, right above the gastroesophageal junction. It appears suspicious even on high definition white light, and AI predicts it 99% chance that this is adenocarcinoma. So this is what will be used for future surveillance protocols in patients with Barrett's esophagus. So this is the review in JAMA I was talking about. What do we do today? You have a patient with Barrett's esophagus, with reflux symptoms, more than 5 years, and has 2 or more risk factors. These are the risk factors. Consider endoscopy. If there's no Barrett's on endoscopy, continue medical treatment for reflux disease in that patient population. If you do see Barrett's esophagus, follow those pearls. Wash the esophagus. Barrett's inspection time. Look for any abnormalities. Do targeted biopsies with virtual chromoendoscopy or AI if you have it. Then take your Seattle biopsy protocols. Grade the dysplasia. Non-dysplastic Barrett's, for long Barrett's, it's 3 years. For short Barrett's, it's every 5 years. Low-grade dysplasia without risk factors can undergo surveillance. If you have some high-risk factors, or you have high-grade dysplasia or early esophageal adenocarcinoma. Those patients can then undergo endoscopic treatment. So with this, I end my lecture. Thank you again for your kind invitation to this wonderful Congress. I hope all of you are enjoying it. Thank you very much for your attention.
Thank you, sir. Thank you, sir. Thank you for that lucid talk. Since you have severe short of time, we will go for the next lecture. Thanks.
Yeah, the next speaker is Professor Pradeep Bhandari. He will be speaking on image-enhanced endoscopy. And we know Professor Pradeep Bhandari does not need any introduction. He's a professor of gastroenterology at University of Portsmouth, England. And he has been trained in Tokyo in early diagnosis of early GI cancers. And he is the pioneers in introducing these services in UK. He has a very keen academic interest with more than 100 peer-reviewed publications. And he has been appointed as the head of research of European Society of GI Endoscopy. So without wasting time, I would like to ask Professor Pradeep Bhandari to give his talk.
Hi, good morning, everyone. Thanks, Yogesh, for arranging this fantastic meeting again. And I'm really sorry that I couldn't come in person as I've just been overcommitted. But thanks for the invite. I will quickly go through aspects of endoscopic imaging, and we can talk about the need for endoscopic imaging. And these are the four headings under which I will go through this talk and go through most of the imaging technologies organ by organ. So why exactly we need? Because there are lots of challenges during endoscopy. All endoscopists miss polyps, some miss more than others. We do miss upper GI cancers. And we do remove a lot of polyps which are irrelevant and have no clinical consequences. Similarly, we take a lot of unnecessary biopsies, again, which are not clinically required. And we do perform too many endoscopies, too many unnecessary surveillance. So all these issues could be addressed if endoscopic imaging is utilized properly. And the reason I say that is that over the years, the endoscope has progressed very rapidly. And every 2-3 years, it's changing. And right now, starting from standard definition to LED endoscopes, the progression has happened rapidly, but I still feel the endoscopists haven't changed their practice at the same pace as which this endoscopic progression has happened. And now we have artificial intelligence, which is just changing the whole game. And I'll briefly talk through that. This is one of the examples from Fujifilm. You can see how they produce this 4 LEDs in the endoscope and utilizing those LEDs rather than putting filters and filtering light in and out in an old-fashioned way. Now we can get BLI, LCI, all this without using filters, just shining the specific LED in specific wavelength. As I was saying that we do miss polyps, anywhere between 15 to 27% of the polyps get missed. And each missed polyp, well, not each missed polyp, but we know that the adenoma detection rate is correlated with reduction in colorectal cancer rate. So indirectly, missed polyps can result in colorectal cancers. Similarly, about 11% of upper GI cancers get missed. And when you compare experts with non-experts for Barrett's, we see that when patients get referred to us, experts pick up another 76% of the lesions which were not seen by the referring center. So there is a problem. In order to fix the problem, well, we need to start with the basics. You see here, most of the time, stomach and esophagus looks like this, with mucus, with bubbles, with saliva. There's no chance of any imaging technology to work, and we will miss lesions. So in Portsmouth, we routinely use a drink with 100 ml of water, 5 ml of N-acetylcysteine, and a few drops of simethicone. We've done a randomized control trial, and where we've shown that in every part of the upper GI tract, lower esophagus, stomach, everywhere, the mucosal visibility increases if you use this drink. And there are a few other trials showing exactly the same. And this is the standard for our practice. And I would suggest that everyone should be using it. Now, in squamous esophagus, in order to improve the detection of squamous neoplasia, which can be very, very subtle, the best imaging would be Lugol's iodine. We use 1.2%. Here you can see on white light, clean Portsmouth esophagus. Still, you can easily miss a lesion till you use advanced imaging. This is eye scan from Pentax, and you can see that there is a subtle alteration here, loss of vessel pattern. When you put Lugol's iodine, then you don't need to look for subtle changes. It is obvious. I think even a blind man can now see that there is a problem here, because Lugol gets picked up by the glycogen in normal mucosa, but neoplastic mucosa is depleted of glycogen, so you get this Lugol voiding yellow patch, and that's where the early squamous cancer is. If you want to stage these cancers of how deep it is, then NBI or BLI helps. And this is a nice classification from Japanese Esophageal Society, which classifies them based on type A is normal, B1 is M1 and M2 cancers, and then B2 is M3 SM1 cancers, and then B3 is advanced cancers. You can see here under NBI how it looks. So this is a cancer which is, we call as M1 or M2, which means it has only reached the lamina propria. And you see these loop-type vessels with no branching. This is typical like coma or loops. In B2, the vessels, the loops disappear. The vessels get elongated and they begin to branch. And this is a cancer which has invaded the muscularis mucosa or even gone superficially into submucosa, that is SM1. And this is obviously advanced invasive cancer. Next is the gastric cancers. They can be very, very subtle when they are early. As you can see on white light imaging, hardly anything is seen. If you put some indigo carmine, you see there is an early gastric cancer. Now, if you know your pathology around gastric cancers, you can look at it and you can say this is a well-differentiated intramucosal adenocarcinoma. Now, it's not indigo carmine which is telling me that this is well-differentiated or this is intramucosal. What is telling me is that it is located in the distal stomach. It is erythematous, reddish in color. It's surrounded by atrophic gastritis, and it is raised to a lesion. That is typical of well-differentiated early cancers. And that's why I say it's well-differentiated. It's intramucosal because it's flat, it's soft. I haven't shown you the inflation and deflation. When you do that, it moves. On the other hand, look at this. This cancer can be very easily missed. See here the pale patch. And when you put indigo carmine, it shows that it is depressed because indigo carmine is pooling in there. Looking at this, we can say this is a signet ring type of gastric cancer. You see that? The reason we say that is because it's in the upper third of the stomach. It's very flat or depressed, and it's very pale. And that's classical of signet ring cancers. Again, and they don't have any atrophic gastritis around them. So that's why this is signet ring cell cancer. You can use NBI, and if you get this kind of fine meshwork of vessel pattern, then that is seen as well differentiated. If you get this corkscrew or disordered pattern, that is a poorly differentiated or signet ring type of cancers. Coming to Barrett's, it is very much biopsy-driven protocol, and despite taking biopsies, we're sampling very small amount of Barrett's, and that's why we're missing 15 to 20% of Barrett's neoplasia. And too many biopsies are required. Doctors don't take all the biopsies as dictated by the protocol. So we need to move on to imaging. This is X1 from Olympus. You can see the white light is so bright that you can see a subtle abnormality. You put the TXI on, now you see the color contrast changes, and you clearly see the margins of this lesion with some red areas, which is suggestive of cancer. You then switch on to NBI, you see a depressed area in the middle, vessels are disordered there, and that is a focus of cancer right in the middle with high-grade dysplasia all around. And Prateek Sharma's group produced this very simple NBI classification, which you can use to detect these kind of lesions. You can use BLI and use this blink classification, which we published a few years ago. You see on white light, Barrett's does not show any problem at all. When we switch over to BLI, again, it's difficult, but when carefully, if you evaluate, you see this slight area of vascularity with a little bit of oozing. And when you use magnification in this area, you will see that the vessel pattern here is normal on this side, but on magnification, the vessel pattern, so this is normal vessel pattern. This is dilated here, and this is disordered. So you can see within the same area, normal to high grade to cancer. So again, in such a long segment of Barrett's, if you randomly take biopsies, you will miss this. If you don't have such advanced imaging technologies, or even if you have, we still use acetic acid. I think for Barrett's, this is the best imaging technology. If you use acetic acid and there is a neoplastic focus, you will get this focal loss of acetowhitening. This is where the problem is. This is a patient with early Barrett's cancer. You see on top of the gastric fold, there's a small depression which is visible, and that will attract your attention. You spray and immediately it loses whitening. In the middle goes red because there's a focus of cancer in that small area. But look at this entire loss of acetowhitening around this. This was not visible at all on white light. And there is all this area is high-grade dysplasia. So if you want to resect it, if you don't use acetic acid, you end up just resecting this area, leave all this high-grade dysplasia behind, and then the patients will get recurrence. So we published a very good classification called PREDICT in gut a few years ago, and I would strongly recommend that you use that in your practice. Coming to colon and making a real-time histological diagnosis with imaging technology, what we call is optical diagnosis. It is possible, and there is a lot of data which supports with BLI, with NBI, that you can make histological prediction as good as pathology. You can see all this data. You can meet the PV criteria as well, which were set by ASG. To see if you can meet those, then you can abandon taking histology. So studies coming from expert centers with various different technologies show that imaging can help you do that. Here is one of the other examples where we use imaging to figure out whether there's recurrence after EMR or not. And you can see that on white light, it can be difficult, but when you use blue light, you can see that these 1, 2, and 3 glands there's a residual neoplasia. Rest is fine. So if you can see this and remove it, patients are not going to get big recurrences. So, as I said to you, there's a lot of data from expert centers that optical diagnosis can work, can predict histology as good as pathologists in real time. But when we replicate this into non-expert centers and start using it at a general level, then we find that it completely fails. This is one of the UK multi-center study, but this similar studies all around the world showing exactly the same, that as soon as optical imaging is generalized into community centers, it doesn't work despite training. So technology comes back to help us here. This is an endocytoscope from Olympus, which produces 524 magnification. And you see here, when we use this kind of technology, I hope my videos will work on the next one. Let me show you. So you stain the polyp with methylene blue, and then you use endocytoscope, you see images like this. It's very easy to interpret this image. In an adenoma, you look at the nuclei, which are a little bit swollen and fusiform, and the lumen here in the middle, you see this? Lumen is like a slit, which is typical of adenoma. When you use this with hyperplastic polyp, you see these little round nuclei with a wide serrated lumen in the middle. See that? Wide serrated lumen. This is typical of a hyperplastic polyp when you use endocytoscope. So, and when it's a cancer, the lumen almost disappears and the nuclei are distorted of variable sizes. So you can make a diagnosis between hyperplastic adenoma and cancer using this. You see, this is a very early cancer in a very small polyp. If my video, this was a courtesy of Dr. Yuchi Mori, who gave me this video. You see here, it's not just using endocytoscope, but they're using endobrain, which is the AI. It's automatically will see and interpret the image. It's got the right image and it's telling you it's an invasive cancer. That was the polyp I showed you in the previous slide, very small. When it's seen with endocytoscope, different areas, it will give you different diagnosis. So you see right in the middle, it is an invasive cancer and it gives you 99% certainty. So this is very, very impressive, but unfortunately, it's a very big, bulky, dedicated endoscope, and it's quite cumbersome to use. So in principle, this is a fantastic technology, but I think practically speaking, I don't think we can use it on a daily basis. So in order to make use of technologies on a daily basis, I feel the way forward is artificial intelligence. Now, almost all companies are producing artificial intelligence, but right now we know that GI Genius from Medtronic can predict, not just detect, but predict histology. CAD-I from Fujifilm can detect and characterize polyps, and Wise Vision from NEC Japan can detect polyps, characterize the nature of polyp, and actually this can also detect upper GI cancers. So I think Wise Vision has got a slight edge over the others. Here is an example of CAD-I. You can see that when you switch on to BLI mode, it immediately tells you it's a neoplastic polyp. On the other hand, if it is a hyperplastic polyp, it's the green heat map, and it tells you that it's hyperplastic polyp. It's as simple as that. So it makes life very, very easy to characterize and make an optical diagnosis with AI. Here is the Wise Vision. You see, this is a very, very subtle early cancer, which can be very easily missed by most endoscopists around the world. But AI from Wise Vision detects this. Once we put enhancement with TXI, you can see this is a very small LSTNG, which is a submucosally invasive cancer. And these are the cancers which can be easily missed. And this is where AI will help us. The other advantage of Wise Vision is that it works across all platforms, Olympus, Fuji, Pentax. So that is the detection. And then you take a still, it immediately trains you high possibility of adenoma. If it is a hyperplastic polyp, it will tell you low possibility. So that is the code word for hyperplastic. Same on NBI. Still, it says low possibility, so it is still a hyperplastic polyp. It also works on Fuji and Pentax, and same thing, high, which is an adenoma. And if it is a hyperplastic polyp, it will tell you that it is a low possibility. It also detects sessile serrated polyps like this, you can see. So I think there's a great advancement with AI that we're going to see in the future with all these AI platforms. This is Wise Vision detecting Barrett's neoplasia. This is really flat, very subtle neoplasia. And you can see the heat map showing the exact location and real-time delineation of the neoplastic focus. Another complex lesion within the Barrett's, it delineates where exactly it is and shows you the location of the lesion on the heat map as well. Also works on various imaging technology. Again, it delineates this small focus of Barrett's. Another case which is covered with squamous epithelium, so it's buried cancer, so it detects the buried as well as the not buried. It's pretty impressive, I think. I'm a little bit biased. This is our data which has just been published in GI endoscopy, where we compared Wise Vision versus 7 endoscopists who do routine Barrett surveillance. And you can see the sensitivity of Wise Vision in detecting Barrett's neoplasia is so high as compared to the endoscopist. And similarly, there's a big difference in negative predictive value. When we look and analyze these lesions, what we found that the endoscopists are very good at detecting non-flat nodular lesions, but endoscopists are not very good at detecting flat lesions. And in Barrett's, majority of the lesions are flat. You can see the big difference between AI and the endoscopist. And I think this is where it will make a huge difference in the outcome in the future. So in conclusion, endoscopic imaging will increase your detection rate. It will help you improve your neoplasia characterization. And the big thing is that the standard imaging does not work as well outside of the expert centers as it works in the expert centers. And that's why I feel artificial intelligence will be the future, where it will standardize the outcome, whether it's expert or non-expert centers. Thank you very much.
Thank you, Professor Pandya. It was an excellent talk about the image enhanced endoscopy. Due to shortage